Neonatal nursing, what does it mean? Well, we know that there are nurses who are right there who are taking care of the babies just as they come to earth at that particular moment and helping them into the world, right? What kind of challenges do they go through, and what kind of, they have wealth of knowledge and information, because this is a very, very crucial stage in somebody's life. One of them is Claire Mukanda. She's here with us. She's our guest for the next hour. Claire, good morning.
Good morning.
Good to have you here.
Thank you.
Karibu sana. We'll talk about neonatal nursing and the work that you do, and I'm sure you have a wealth of knowledge that you'll share with us. But before you do that, Janet is going to give you the day's quote. Words that were said some time ago, and then let's see whether they make sense to you today.
Yes.
Not an exam.
It's not an exam. I know. Claire immediately, it's almost like she went to med school.
Yeah,
she was like,
right
wait.
back there. Like, oh, wait.
Wait. Because the Constitution of Kenya is turning 15 tomorrow, this is really based on the spirit of that. A lawyer and scholar in 1991, through an essay, he said, Africa is littered with constitutions without constitutionalism. That was Okoth Ogendo. He said, Africa is littered with constitutions without constitutionalism. Do you agree?
Yeah. It's led with constitution without constitutionalism because we don't follow the constitution. Ideally, we apply it when it favors us. That's when we follow the constitution.
Yeah.
Tukijisikia.
Yeah. Which is not how it should work.
Yeah.
But that's true. We do. It's when it suits us.
When it suits us, we are into it. When it's not with us, we throw it out.
That's true. Like as we get into this conversation, I think the implementation of healthcare does not exclude newborns, right? And as a neonatal nurse, just give us an overview. Let's start with people who may not be familiar with the term neonatal. What does that mean?
A neonate is a newborn delivered before 36 weeks of birth. That means that not fully matured. So this is a child who has been delivered before 36 weeks of birth. That's a child who needs close attention, close monitoring, and needs totally full assistance for her to mature and be like any other child born at term.
Okay. Do you have, I know there's actually a report by Kemri that you're referencing, but what are the rates of now neonatal births in Kenya? And yeah, how prevalent are they? How many children are delivered before 36 weeks?
I might not have the exact figures, but it's on the high, it's on the growth, because we have cases like preeclampsia which are on the high. So most of the mothers, when they get that pressure when carrying the pregnancy, it leads to preterm babies. Yeah.
Okay. Yeah. And you will correct me if I'm, but just looking briefly at the brief that Mariam has just referenced, it says public hospitals, one nurse cares for a median of 19 babies per shift. Yes, and time per baby in Kenya, 30 minutes in a 12-hour shift versus 326 minutes in high-income settings. So with that, I just want to ask you what you feel the status of neonatal nursing is in Kenya. Are we where we need to be, or are these numbers speaking to the reality that you all face?
We are not where we are supposed to be. The numbers, as per the research that was done at Kemri, we are there. We are not better off. We are at the worst because one nurse attending to 15 to 25 kids, and those are, now you include the mother because the mother is also there. So it means one nurse to 50
people.
Yeah. Then you tell me I'll take 30 minutes per child in a whole day. If a 12-hour shift, then it means the first child I attended to, by the time I closed business, I have not gone back
to check on them.
That's what the neonatal nurses face each day.
Nurse, walk me through this. So when a child is born preterm, and this is before the 36 weeks, what happens? So where are they taken?
They're taken into a newborn unit.
What's that? What does it have? What happens there?
This is a unit that has incubators. heaters to keep that warmth, because they still need that warmth before birth. So we try to maintain the temperatures that were initial. Yeah. So this child is supposed to be fed because hasn't gained all those sucking reflexes and the rest as per. This child needs to be bathed. This child needs to be kept warm in an incubator, which means even the turning of that child, we have to ensure she's turned and positioned well each and every time. Feeding, we have to monitor the body temperatures. We have to monitor her system. How is it? So,
how do you feed this child?
Via nasogastric tube.
What's that?
There are some we feed via spoon and a cup when we realize they have the sucking reflex. But there are some who are born at 1 gram. 1 kilogram.
Oh, 1 kilogram.
Yeah.
Okay, that's very small.
Those are very tiny kids. We put a nasogastric tube through the nose to the stomach. So that is where a nurse will stand there with a syringe to ensure that milk, mother has expressed the milk, has to ensure that milk goes in slowly by slowly. Now tell me if I have 15.
How many times per day does this child need to feed?
You're supposed to feed around 6 times a day.
6 times.
For the one child?
Yeah.
For the one baby?
I'm feeding like how many meals? Less than 10 meals now. So I have to be there, but I have 15 of them.
It's just an overwhelming burden.
6, yeah. 6 feedings a day, and you have 15 children that you're attending to. Potentially, it could be even more.
Yeah.
Maybe it could be less in private facilities, but
it's still a high number. So the exhaustion is real. Is it possible to speak briefly to why preterm births? I think one of you had asked that, but are we seeing it on the increase or on the decline? I know that sometimes health is it's not linear. You can find that for different reasons, certain conditions are worsening or getting better. But from your observation, are we seeing more preemie births or less, or are we just seeing a stagnant number?
They are becoming more.
They're becoming more.
Because of stress. The conditions, that health conditions, diabetes, the lifestyle diseases. Like for a diabetic mother, you see, we have to ensure we get up. We secure that child from getting complications and having a stillbirth. A mother with hypertension. And those are the diseases that we are experiencing at the moment.
All right. So maybe actually those are the causes of most preterm births.
Yeah.
So hypertension, diabetes, preeclampsia is a form. It's hypertension. Okay.
Yeah.
Sorry, there's I think a research that I'd seen conducted by some researchers across various. Aga Khan University was one of them, some universities in Finland and Ethiopia, and Cameroon was also involved. That was looking at the number of preterm babies that are born. There are very many across the globe, but in the developing and non-developed world, like in Africa and Southeast Asia and Latin America, they're higher. Some of those reasons, according to those researchers, are reasons that could be avoided with proper antenatal care and visits. In terms, for example, of monitoring a mother's blood pressure levels, blood sugar levels, monitoring a mother's diet and stress levels, and so on and so forth, and being able to just caution and manage, walk through this. So when we see them rising, what does it tell us about the antenatal visits and antenatal care?
Right.
I would say we have challenges with the economy. You tell me to start antenatal at 12 weeks. Even in us mothers, do we really go at 12 weeks? We wait until we are 6 months is when somebody is seeking antenatal care. When they take my blood pressure, it's already
high.
So by the time they have to work on it to come down. And once you tell an expectant mother something is abnormal, that's already a signal to her. It's already
so the stress now.
The stress builds up.
Yeah.
So those are the gaps. Attending antenatal clinic is supposed to be even before. It's supposed to be something you've planned for. I want to get pregnant. I have to start seeing my gynecology before in preparation to it. But how many Kenyans do that? Our economic status, do they allow us to do that? Because going to a gynecologist is some money I have to pay.
Yes.
Can I start before? I'll only look for a gynecology when I have a complication. I'll go for the routine antenatals to any public hospital that I'll go and pay 50 bob for a checkup and then sorted. Yeah.
Actually, what you said about antenatal beginning should begin before conception.
Yeah.
Sorry,
Yeah.
used to be.
And it's a process.
Please, just explain. So if you have the intention of conceiving,
Yeah.
you should already start.
Yeah.
So that how far?
Having a
before?
conversation with your gyna,
Yeah.
having all those
Okay.
checks and
Yeah.
all, right?
Yeah.
Okay.
And then
just
once you conceive, at that particular moment when you confirm that you're pregnant, you begin your antenatal journey at that point.
Yeah.
This is where the, what are they called? CHPs come in.
Yes, I was just
Isn't
going to
it?
say, yeah.
Because then they'll be doing those regular visits to homes in those early weeks and advising you to start going
For the antenatal.
for the antenatal clinics in the nearest health facility, which should be able to sort you out. Do the CHPs and the nurses that I'll find at the level 2 dispensary or the level 3 health center, do they have the actual proper knowledge and equipment to help me with that journey, to help detect the challenges?
The knowledge they have, yes. But the challenge is, I'm doing this like the CHVs. Are they being compensated for the work they are doing?
I mean, they are supposed to be.
They are supposed to be.
Yeah.
But are they getting it to the level of their expectations? So a mother will seek for a CHV when she's noted some abnormal. I'm now having abdominal pains. What could it be? Then I'll go for a CHV, the near one. Then she'll tell me go to the health center.
Yeah.
I'll go to the health center. The nurse refers me to the level 4. When I don't have the money to even travel from where I stay to the level 4, what will I do? I'll go back home.
Yeah.
Wait for another signal. Then
now that's when you'll go.
you see, those are the
That's
those
the
are
reality.
those are the realities for our mothers living in the rural areas.
You know, I think about how already when you have an element of access, because even in my it's frequent and it takes a lot of intentionality and planning to make it for all the visits. Like even sometimes I was like, must I? I know it's important.
I'm fine.
Everything seems fine. Of course, there's a panic but you don't know unless the baby's checked.
Yeah.
But when you think through how often you're going, what it entails, it's a lot.
Right.
So there's an equity
Even
issue
with resource.
to access. So Claire, if you to think of the gaps, because we've heard about staffing, policy, which other one is there? I'm trying to point to
I think our
attitudes.
not attitudes,
Knowledge.
but knowledge. Yeah,
Knowledge.
because what you've spoken
Awareness.
of, awareness is that people will wait until there's a pain to even go to the CHP.
That's true.
Right?
Yeah.
And then again, resource is tied in. If there's no resource for me to go to the level, I'll just go back home and just be like, let me wish it away, which is how we approach healthcare as a whole, not just antenatal care. And
Which is so
prenatal.
dangerous.
Yeah.
Because I wanted to ask you whether how you then collaborate or come together to raise these issues, say with the ministry, and whether there is any way that you're beginning to be heard or supported, or whether there's still a very big gap in improving even just the staffing issue, the policy issue. Do you come together as nurses and just say, these are the issues we're facing? When you do, what are you being told now?
I think I would say congratulations to the CS. Yesterday we had him say that all those nurses who are under universal health coverage are being absorbed to the knee. That's just, but they were still in the system. So we need more.
Okay.
We need more.
They were
As
already
much
serving.
as they were already serving, but under universal health coverage. Now they are being absorbed into the permanent and pension. So we would request the CS to hire more. If we can even start with a contract and then they'll cover the gap. Because if I can get 3 nurses added to that neonatal unit, then it will reduce the ratio, and also my time to attend to this kid will at least increase from maybe 30 to around 45 minutes, then I can do something. Because if there's a shortage, there's delayed of service.
Yeah.
I'll not feed on time, I'll not monitor this child on time, I'll not even have time to talk to the mother. Yeah? And counseling is continuous to this mother. You have to reassure me all is well with my baby. I've entrusted, because she's coming expressing her milk and going. It's you feeding this child.
Walk me through your shift.
Yeah.
You've given us a bit of insight into the time that it takes to feed. But walk me through your shift from the minute you put on the scrubs and you start the shift.
Here is a nurse who reports at 7:30.
Okay.
Receives the report. I've been handed over this, and this. And in that handing over, there are kids whom you'll find they are very sick. You'll find kids who are stable, whom I can tell the mother, please feed for me. And there are shifts that I'll get, this child is very much vibrant. I can even tell the mother, can you breastfeed? But now, for me to give the best care, I'll give priority. There's some kids who are on a machine who still need my attention. I'll start with that priority. And I'll miss an opportunity of a child who was stable, who has changed condition. Yeah, you see? Because I'll be concentrating on this one on the machine and the sick one. I'll have to give medication. Feed, give medication, bath this child, ensure she's comfortable. Go to the next one. Go to the next one. I'll have instructed the mother to feed for me this. But what if this mother is feeding and then the child aspirates? Who is to come back to that rescue? It's me, the nurse. So that nurse, the neonatal nurse in that unit, has already something clicking in her head.
Right.
What do I do? What do I hold on first?
Yeah.
Is this child sick, or is this mother who has a child who has aspirated? Yeah.
That's entering. Let's say you do your first round of feedings.
Yeah.
How long would that take? Feedings and check-ins, you've gotten the report?
I have to feed and finish with this child if I want to complete my procedure. Feed, give medication, then ensure the child is comfortable before I go to the next one. If we say I feed and then I go to the other one, it means I'll gown and ungown. And this nurse will have to dress how many times to?
Okay. So by the time you're done with one child, how many minutes are we looking at?
The study showed that is one child, 30 minutes.
Yes.
30 minutes.
Yeah. That's a lot. This something here about patterns in shift patterns in newborn units. Morning shifts busiest, 3 to 4 nurses. Afternoon shifts lighter, 1 to 2 nurses. Night shifts longest and least staffed, 1 to 2 nurses, often alone with an on-call doctor. Worst staffing between 4:30 and 6:30 p.m. Sometimes only 1 nurse is present. And then the coping strategies, and maybe Claire can react to this. Patient prioritization, babies classified into critical, stable, or recovering. Task shifting, routine tasks like feeding, monitoring, hygiene, even medication handed to students and mothers, often without supervision. Claire, you'll speak to this and let us know. Collective coping, informal staffing adjustments when colleagues are late or absent, and improvisation. And these sustain care, but they normalize inefficiencies and risks. Which of these is the riskiest, Claire, that you see? Because this is coping, because you're trying to make up for being short-staffed. And so then these are some of the ways that the coping is done. But which of these is the most concerning? Here it says students and mothers often without supervision. Yeah, talk to us about the one that you're most concerned about right now.
Now, even the hours. You're talking about shifts. We are talking of the whole day, 12-hour shift. In Kenya, we don't have the split shifts of 6 hours. It's 12 hours. And us is in that unit.
So when you get in at 7:30 a.m.
you leave at 6:30.
We are till 6:30 p.m.
Yeah. Like there was an instance in Kerogoya when one of the neonatal nurses told us there was 1 staff on duty with 48 babies.
One nurse?
Yes, 1 neonatal nurse with 48 babies. Now tell me, what time will she even have to take a cup of tea? And she's not nursing 48, remember? She's nursing 96 because even the mother is also psychologically sick. So we don't have shifts in Kenya. We would really request if they can consider shifts, especially in the newborn units. Let a nurse work for 6 hours. Even the heat in the newborn unit, because the heaters are on.
It's hot. I'm thinking through, and I look through best practice globally. But when you do this 12-hour shift, do you do the next day 12 hours, next day 12 hours, next day 12, and so on? What does that week look like? Is it 3 days on?
How many days on,
2 days
how many days
off?
off?
Yeah.
Ideally, it's supposed to be 3 days, then you go off. So even if it's 1 day, 12 hours, you're already drained.
You're drained.
tomorrow you are coming. But remember, there's a nurse who is also doing a night shift.
Yep.
Is going now. The one who handed over to you is coming tomorrow.
Yeah.
You see those. The ratio of nurse to patient ratio in Kenya is still not right.
Before we go to the break,
not right.
I'd like to know, what does it take to be a neonatal nurse?
And
are you different from other nurses in training, in experience?
I would let you know that neonatal nursing was introduced in Kenya in 2012. So it's not been there. But the newborn unit has been there since. So by 2018, we only had 100 nurses trained in neonatal care. Most of the nurses we have in the neonatal units are trained on job. You have the basic knowledge. So when you come, you are deployed in the neonatal unit, you'll not say no. You'll have to start, recall what you were taught, and adopt what you are getting on the ground, and then work out as a neonatal nurse.
Oh gosh.
What's that training? So are you first a nurse and then you specialize in
Yes,
neonatal
you
training?
can. As a nurse, you finished as a diploma nurse, you go and specialize in a higher diploma in neonatal nursing. Previously, it was a 1-year course. Currently, the Nursing Council has said every higher diploma course is 2 years. So you go in for a 2-year course. And it's not in all MTCs that are offering neonatal nurses. That's why you see there's a shortage of neonatal nurses in Kenya.
Because there's a shortage of training facilities.
Training facilities. Like for now, it's Gertrude and Kenyatta National Hospital. I think those are the ones I know of. If we have another one, I am not aware of.
Okay.
So they can't train even more than 500 or 100 or more than 200 in Agu.
Yeah. Is there demand from the diploma level to higher national diploma level for neonatal nurses?
Yeah.
Are we seeing more and more nurses wanting to pursue this?
Yeah. More nurses are interested. But the
KMTC
slots are also...
Does KMTC offer neonatal? No. So just Gertrude's and KNH?
Yeah. At the moment, I've noted of Gertrude's and KNH. Yeah.
Okay, let's come back after the break. Claire Mukanda is a nurse. We're talking about neonatal nursing, the gaps. Hopefully we'll get to the strides, and to your point, think of the models that work globally and how we can begin to transition them in Kenya. But it's coming up to 7:30. We'll also look at some of your feedback after the break.
100. Yes.
Idris Boru says, I've realized almost every sector in this country faces many challenges. The main cause here is lack of allocation of enough resources. Yet resources are there, they're only mismanaged. And I think Idris was going to come up with a solution. So Idris, finish your statement in our chat to talk about what solution you think is necessary, the fix, which we're trying to have a conversation around neonatal care and nursing this morning.
That's right. We're also going to, we're also taking calls if you have questions around neonatal nursing and healthcare as a whole. Our number is 0719038858, 0719038858. But I was going through some global best practices, places where neonatal healthcare and neonatal nursing are, considered to be top-notch, where the rates of neonatal mortality are extremely low, and they're able to, of course, have as many preterm babies make it out of the hospital and live now full, healthy lives. And I was looking at the best practices. One of the best ones that comes to fore is a hospital in India, where it's considered a benchmark in general. And the things that they have as far as survival rates, they have an 82% survival rate for extremely low birth weight. This is less than a kg. Babies born less than a kg. That's 82% survival rate. I think that's incredible. It exceeds the national average of 40 to 50% in India. Now, they, of course, have strong clinical protocols, advanced equipment, including ventilators, phototherapy units, human milk banks, and others. There's also kangaroo mother care and maternal support. So let me just begin with asking Claire, before we even go into anything, equipment-wise, how are we doing? Ventilators, human milk banks, do we have those?
Yeah, we have one in Pumwani. Pumwani has adopted that human milk bank, which we are hoping it will continue. It's doing well.
Okay, just explain it. Just explain a human milk bank.
This is where a mother can produce, who has enough milk or more, gives that milk. Remember, Mercury has to go through screening.
Yes.
to offer milk to a baby who has a mother who is not able to produce milk. Yeah.
Okay. So human milk banks, we have one at Pumwani,
Yeah.
but it's the only one in the country.
At the moment
it's doing well, though.
It's doing
okay.
well.
I'd love to get someone from the ministry to figure out, are we planning on scaling?
Expanding it.
Yes. Ventilators?
Ventilators, we have them, although not enough for all the counties, we would just request for more equipments in our county level 4, level 5 hospitals so that we don't have referrals. You know, referrals, the time for referrals also contribute to the life.
Yeah, it's a
The
critical
health
stage of a life.
Yeah. So ventilators and equipments for neonates, like the CPAPs, are needed in the level 4 and the level 5. Yeah.
Oh, wow.
They are not enough.
Okay.
Yeah.
Level 4 and level 5.
Even level 3, because all those nurses, even level 2 is a nurse, and she went through pediatric nursing during the basic training. So if she gets those equipments, believe me, she can do wonders. Yeah.
I like that.
Yeah.
Kangaroo mother care. What's kangaroo mother care?
Kangaroo mother care is where this mother holds, it is skin to skin. The baby is on the mother's skin and then wrapped there.
Okay.
Just to provide that physical warmth. Yeah. And bonding.
Right.
Yeah.
Why is it important?
It is important because it creates the initial bond. Remember when you deliver normally, that initial breastfeeding is a bond. Here is a child who cannot breastfeed. You just it will just have that bond. Even the mother herself, she'll feel a sense of, I have a belonging.
Okay.
Yeah.
So in a day, how often would the kangaroo mother care take place? So you have this preterm child, baby who's been born, and you've got the mom here. How regularly do you want them to have this skin-to-skin contact? Because they're both in the neonatal unit.
You know, we'll also base on the mother's health for the kangaroo care. If the mother is willing to be there more often, we wouldn't deny her access to the baby, because this is a bond we want to create that will even go beyond the hospital setup. Yeah. So once the mother is free for that and the child has been fed, is okay, it's good to go.
In the many unfortunate cases where the mother dies and the baby is left, what happens?
At the moment, we are trying to bring in, even if the sister is willing to offer the support, or the father to the baby is willing to offer the support, we are encouraging, as per the research, we encourage even the father to be there to provide that kangaroo care. Yeah.
I want to go back into this neonatal unit. So I know that there's a neonatal nurse, because we've been talking about that. Who else is in this space?
We have the nutritionist, we have the pediatrician. It's a multidisciplinary team.
Right.
Okay.
Just as a hospital setup is, we all have those disciplines on board. Because if this child changes condition, the neonatal nurse has to signal the doctor around. There's something wrong with the feeding of this child, the nutritionist has to come on board. All those, even the support staff is very essential to ensure that flow is clean. So that this nurse, as she navigates through those baby cots, she's safe.
That's
So-
actually one of the best practices, cleanliness. This was from, I'll get the hospital, but yes, introducing ward assistants tasked with environmental cleanliness, waste management, and caregiver hygiene, significantly improved some best practices. And of course, this was actually in Kenya. Yes, enhancing infection prevention and control.
Yeah.
Yes.
You know, there are some nursing duties that nurses do. Like, I carry this file, I have to deliver it to somewhere. Those are the things that, if we can get the ward assistants, they do those nursing practices.
Right.
Yeah.
It's so strange.
I
The
know.
internet cites Kenya. That's the source of this.
Are we the ones feeding AI and the internet
Right.
this information? Because
Right.
it always sets.
Yes.
Such
or,
a high
or maybe
bar.
we go through a moment. You've done this for a long time, Claire.
Initially, I'm not in the neonatal unit, but I have seen it go on as I'm part of the hospital setup. So if I am the only nurse, this file has to be taken for medication. I have to order the drugs for this child. You see, where am I when the child is needing my attention?
Right, and you've already given us the numbers.
Yes.
So this 15 children, 25, and their moms, all needing care, ranging from stable
to the very sick.
To the very sick. And then could be switching between those places again, and then you still have to run, order medicine, give files.
And you're one person. I wanted to ask you what you've seen get better and what you've seen get worse in your experience.
You know, during the attention I'm giving to the critically ill, and then you get somebody who has changed the condition. You know, by the time you navigate through, even in your brains, to settle that I was attending to this one, I have to attend to this one. By the time you switch that in your brain,
takes a minute.
You'll have missed something. There's a missed opportunity that,
No, but I mean, over the years that you have been a neonatal nurse, what have you seen improve as far as our neonatal nursing and our neonatal care, actually, the whole ecosystem? What have you seen get better?
Even the introduction of the neonatal nurse course has opened up. You know, it has given those, you know, during the nursing profession, you are just training everything. ICU is there, pediatrics, orthopedics, the rest are all captured there. But when you specialize, you see, as you specialize, you draw your attention and interest to that specialty. So for the neonatal nurse, their interest is now in that neonate, you see. So as we go by, when the Nursing Council introduced the neonatal nurse course, it has added value to the nursing, because now this nurse is focused to the interest of her choice.
Right.
Yeah.
I like that.
And it has improved care, by the way. Yeah.
I was thinking through the staffing crisis is clearly still a big one, and we may not have numbers, but you said less on the break. You said probably less than 1,000 countrywide. As of 2018, we were 100. Even if we multiplied that tenfold since then,
we are 7 years now.
Yes,
God, it's 700.
It's not much. There's also the brain drain issue. How many skilled? Okay, all nurses are skilled. How many nurses, in your estimation, just from your knowledge, right? How many nurses are leaving the country to look for greener pastures outside? And what is that doing to our healthcare?
Ideally, every day there's a nurse leaving the country. If I'm not very wrong, every day there's a nurse. And as I say, every day there's a nurse doing NCLEX. Why am I doing that? I'm looking to go outside. So nurses are leaving the country. And I cannot even say 10 or 15. Because there are times even they go like 20.
Oh, God. At a go.
At a go.
Yeah. It's probably because there's more support in some of these areas, right? Because psychosocial support is also something. I think about, just having to do all those shifts. You've already spoken to the burden, emotionally, physically. So do you have to just encourage each other? Is there a system that allows you to have some kind of psychosocial support, or is it being introduced formally?
Nurses work as a team. And we do cluster care. Because if I say that I work as an individual and we are 4 in the unit that time, believe me, I can't do anything.
Right.
But we work as a team. When we are in that unit, we work together. If I know a colleague has something that needs my assistance, I'll rush there to assist. Yeah. And then we also have that continuity, handing over, and communication to just give the picture of what is gone and what we are expected to do. That continuity of communication, cluster care, mother involvement. By the way, we involve the mothers. The mothers are involved in the neonatal care more than 100%. Because each and every time this mother comes, you have to tell her, this is what we are doing. This is what you are supposed to do. If the child is stable, you are the one encouraging her now to feed with a spoon or a cup. You see? So with that, it gives us that gear to move on.
Right.
Because if you realize you are 4 and you have to work, what will you do? You have to work as a team and then carry on.
You carry on. And you have to have a positive outlook. I'm looking at this research by Kemri. And there's what they sought to do in their research as an intervention in seeing whether if we increase the number of workers in the neonatal, in the new birth unit, things would change. What's a ward assistant? Who's a ward assistant?
I would say they are not nurses. Let it be clear that ward assistants are not nurses. They are there to assist in the non-nursing procedures.
Okay.
Yeah.
Okay. Are they trained? What kind of training do they have?
Basically, I cannot even define the training because I hear that we have several institutions offering the ward assistant course. But I've never gone into details to know what they offer.
Okay.
Yeah.
But
you
they're
know
not
what they
graduate
do.
nurses.
Yeah.
But you know what they do on a day-to-day. So like you said earlier, you want
somebody
to
assist me carry this file, go for me for the medication. Yeah, ensure at least where I'm working there is infection prevention. Yeah.
I would see it as critical
Very.
because any extra set of hands
Yes.
that
helps.
allows me to focus on mother and baby.
It's
I
a
think
thumbs up, yeah.
I
This
think it's
research actually shows what happened in this particular intervention. They are
Yeah.
aiming to improve nurse staffing and the quality of neonatal care by introducing additional nurses and ward assistants
Yeah.
to the new birth units at public hospitals in Kenya.
Yeah.
3 additional nurses with intense 1-week training in neonatal care were introduced to 4 new birth units, each
Yeah.
for 15 months.
Yeah.
These units had 10 to 17 nurses before the intervention.
Yeah.
So they increased the staffing of nurses by about 37.5%.
Yeah.
This level of increase was considered something the policymakers in resource-limited settings might realistically achieve. So this is something that you could do if you just added 3
nurses. Yeah.
to the existing
To every shift.
nurses.
Yeah.
After 8 months, 3 ward assistants per unit were introduced for 7 months. They were expected to take on non-clinical duties and provide general ward support, allowing nurses to focus on skilled patient care. The job description and linked 1-week training for ward assistants were co-designed with senior nurses and hospital managers to ensure an agreed scope of practice and aiming to ensure their implementation did not disrupt workflows. So they say now the result of that was a modest increase in nursing time per baby from 34 minutes to 43 minutes per child. That's a 25% increase. But this 43 minutes spread over 12 hours for each baby is still limited in a typical week comprising 7 12-hour day shifts and 7 12-hour night shifts. Adding 3 new nurses would mean adding only 1 nurse to 8 of these 14 weekly shifts. So still not much. Although the intervention added new staff, existing nurses who had not previously been able to take leave due to staffing shortages were able to take leave. This improved nurse well-being, reduced the expected increase in patient care. At the same time, extreme workforce pressure in hospitals sometimes led to nurses redeployment to other departments. As a result, average nurse-to-patient ratios saw only small improvements. But there was something. There was improved work efficiency. There was stronger teamwork and collaboration. There was enhanced nurse well-being, greater peer support, expanded learning opportunities where nurses were playing a more active role in training junior doctors and students, for example, and in tube placements. There was faster adoption of some of these technologies because nurses had a bit more time. So just adding the number of nurses, but not just the nurses, but also seeing how can we then add extra hands here. But they are properly managed by the hospital management and the senior nurses are also involved. It helps.
It does. So you're also not disrupting what they're doing day to day, but you're on hand to step in to allow them to focus on.
I was thinking of technology. If there are ways that technology can be used to also plug some of these gaps. Are there tools, devices that you can think of that would be helpful? We increase the number of nurses per shift, but if there's a tool that could also help take off some of the work off the nurses' hands so that they can focus on baby and mom.
I don't think there's something nurses can can
It's one of
replace the
those
work-
professions. It's one of those professions, yeah.
Nursing is one of the professions that you cannot use a technology or a robot to do the nursing side. Yeah.
I'm trying to see something that came up in Malawi, according to an article in The Guardian. At a health center in Malawi, a clinic implemented AI-enabled fetal monitoring software, which tracks the baby's vital signs. Over 3 years, it says, according to this article, stillbirths and neonatal deaths fell by 82%.
Okay.
Mobile app diagnoses birth asphyxia via baby's cry. Wait, this is according to ARXIV organization. So I think mobile tool dramatically reduces delays and resource needs in detecting critical conditions. So I think it's
to what she said.
Yes.
Like when you're doing the rounds, there could be a baby that you left in stable condition, but it changes.
Yeah.
And because you're doing rounds, you're not able to tell. So yeah, if there's a tool monitoring their vitals,
Okay, and then it gives an alert.
Then,
Okay,
yes.
okay. That one.
I think the combination of more hands and tech would be the solution
Would
here.
yeah.
Because there's also an emotional element that you need to have when you're doing this work. It's not just clocking in and out. It's like paying attention. I think being a nurse is, I don't know, you have to have a lot of grace. I also sometimes think about how sometimes the mom also wants to be a professional. So I can imagine, let's say Claire, it's her shift. She's already done 11 hours. She's telling you what your baby is going through. No, but I read.
And I want my child also to be given that
to be
attention.
given this. So you have to be calm.
Because each and every time a mother comes, she wants you to listen.
Yes.
The first thing is listen. Just listen to her. That is enough therapy you are giving to this mother.
Which is
But if you
nice.
come, I'm exhausted. I'm human.
I can snap.
What response will I give?
To listen.
now you've already explained the way I would.
Yeah, because I see it, from the practitioner, you want to give the best, but you only have so much as well. You're,
Right.
like you said, you're a human being, not a robot.
Yeah.
And as a patient, a mom, as the baby, you deserve the best healthcare as
Yeah.
well, and it's good to advocate for yourself. So now it's who plugs the gap
Yes.
that allows both people to do their job well and to receive quality healthcare.
Yeah.
And that's government, like 99%.
Exactly.
And remember, we have an association that trains these nurses. By the way, you have the National Nurses Association of Kenya, led by our Honorable Colin Sajwang. It has a chapter for pediatric nurses. They come together, they share knowledge from different counties. They share researches they have done on how to manage the babies. So with all these on board, the nurses are equipped. They are ready to go. But where are they?
Where are they?
I have the knowledge, but how much will I disseminate?
Right.
Yeah.
That's a gap.
Oof. As we close the conversation, we just have about 2 minutes. Speak to one, government staffing and regulation. 2 things that could help. Staffing, you've said increase, yes, but like how many potentially neonatal nurses could we use start with a level 6, level 5, level 4, and then from a regulation perspective, if there's anything that we should be doing to make sure that we have like a steady eye on what is happening with neonatal nursing and we have standardized care.
About the ratios, maybe if our government could employ more, as much as I've emphasized on hiring, to ensure that we just at least minimize the number of neonates being attended to by one nurse to a ratio of, maybe if we go down to 1 to 6, it will have an impact to our neonates. And that not withholding, maybe the government should involve even the NGOs, the non-governmental organization, to come on board to assist the government, hire more staff, get more equipment. Also benchmarking to get more technologies. What is Malawi doing better than Kenya? And that can only be attained if our government will empower the nurses. Open up our MTCs to train more neonatal nursing.
Yeah.
Let's have a training of neonatal nursing, maybe in every county. Yeah, specialized training.
Even every sub-county.
Yeah, specialized training. Let it not be when the nurse wants to do the course. Let it be a burden to the county that if I want to do critical care,
I must have.
Let the county release nurses to go and do critical care. if they want to do renal, because it's not even neonates alone who are suffering. We have cases of renal care that cannot be handled in the counties that are being referred to either Kenyatta National Hospital or to a private sector where those insurance covers are not taking. So if we can have the enough staffing and with well training, we have the training, we have the online courses, but for a nurse, you can't do online 100%. You have to be hands-on. You have to be hands-on to attain that.
Right. Claire Mukanda, a nurse, talking to us about neonatal nursing, the strides and gaps, the burden, the opportunities, and hopefully this speaks to what can begin to be a change in support, especially for the nurses. In the next hour, we speak to the Judicial Service Commission. We'll have Lady Justice Fatuma Sichale, and we'll also have Vice Chairperson Isaac Ruto. How well is justice being served 15 years after the promulgation of Kenya's constitution? That conversation is next. It's coming up to 3 minutes to 8 a.m.